Okay, good evening, everyone. And I'm going to start this session. Can I ask you one question before we start this? How many of you here who have submitted questions? We had a lot of questions. But how many of you are here who have submitted the questions? Okay, all right. So maybe I think we will give priority to, you, and then go to the other topics. So first of all, I have to thank the organizers, particularly Dr. Fernandez and Sunil Pandya, and their organizational group and the support staff for producing such an amazing conference. Actually, we really enjoyed this, and we sincerely thank them on the behalf of all the faculty, from us, from overseas, the national faculty, the regional faculty, and the local faculty. I think we should give a good hand to Sunil, for organizing this.
Thank you so much.
I think he truly deserves. He truly deserves this.
Thank you so much.
And of course, I also must thank all the delegates. See, without the delegates, there's no conference. Be it be the residents, be it be the fellow anesthesiologists, senior anesthesiologists who have long experience to express. It is a mutual learning process between the teaching faculty and the delegates. And so I also thank all the delegates for coming. And sometimes in the discussions, we do have some heated arguments. And that is a part of the conference. As long as we don't pull each other's hair, it is fine. Because when things go wrong in your practice, you suddenly think about, these kind of discussions that went on in these meetings, and something will come up from these meetings for you. So with that, I will, just move on to the... Is this working? I just want to, the last Society of Obstetric Anesthesia meeting, I moderated the case discussions. That was the last session of the meeting. And I say one thing. You all see how the candle burns the candle flame? When it is coming towards the end, it becomes much brighter and then extinguishes. So that is this session, actually. And in that, I moderated one case report, which I need to actually just give a short presentation, because that we gave an award for that paper. The title is Tuhi to ECMO. So a healthy patient comes to the labor and delivery floor. They put an epidural. Things seems to be fine. They give the loading dose. For some reason, the patient actually went into total respiratory arrest. Actually, it became a total spinal. So they intubated the patient because of hypoxia. In that process, she aspirated. And so after the baby delivery, they tried to ventilate the patient in the ICU, had severe respiratory distress syndrome, and they have to put the patient on ECMO. And finally, of course, she survived. But look at, a normal, healthy patient can come to us, and finally, we do not know the outcome. Everything looks fine, and everything suddenly falls apart. And Dr. Kamen actually wrote something, never dull a moment in OB anesthesia. Now, this is something I just want to show you. This is a simple code box, very inexpensive. And whenever we provide anesthesia, when we are called for an unusual locations from our usual locations, we carry this box, and sometimes with an AMBU bag, just as a backup. It contains a simple laryngoscope, endotracheal tube, LMA, a bougie, and resuscitation drugs. And it is not that expensive. In fact, I found out the pricings in the Indian rupees also here. It is much cheaper than the outfit we are wearing today for this conference. Now, let's proceed to some of the questions, actually. The first question is there any term or mechanism for auto-regulation of placenta and range of blood pressure if present. And is placenta considered an end organ? And Dr. Ramkumar, would you like to address this question?
Yes. To answer the first question, is there any term or mechanism of autoregulation in the placenta? I believe that the placenta is a low resistance circuit, and it is one of the last circulations to kind of pack up, if at all there is a drop in blood pressure. And even if there is an autoregulation that is there in this circuit, it should be much lower than the range of autoregulation that you find in all other organ systems. So I think because by nature, the placenta is meant to be, for the exchange of gases and other nutrients between the mother and the placenta and the fetus. It is essentially a low resistance circuit. So I don't think, to my knowledge, that it has any range of autoregulation. I'd request the other panelists to add on to that. And the second question was, it's gone off from me. I can only see my face here now.
Yeah. Is placenta considered an end organ?
No, because again, when you say a placenta is an end organ, I presume that every vessel that is supplying the placenta would be an end artery kind of thing, but it is not. It's a kind of a common circulation. It is not an end organ.
Okay. Now, since we are in the subject of uterine circulation here, what about phenylephrine ephedrine controversy on this? On this circulation. I mean, that is where initially we used to give ephedrine thinking phenylephrine does something bad, and now we say phenylephrine is good. So how does this affect the circulation? Any one of the panelists can jump in here.
Phenylephrine is a drug of choice for low resistance, like when the SVR is very low, because it selectively acts on the alpha receptors and causes peripheral vasoconstriction. And it has a sparing effect on the uteroplacental circulation. And in fact, it does not affect the uteroplacental blood flow compared to that what other vasopressors or ephedrine does. So despite maternal hypotension, it doesn't induce any fetal hypoxemia, even if there is a maternal hypotension if you use phenylephrine, vis-a-vis ephedrine or any other drug.
That is absolutely the current thinking. That is why actually in fact, one of the sales rep of phenylephrine said that in India, phenylephrine is not being used that much as we anticipated from all these talks from the, conferences. So I don't know what is the general. Pardon me? That's not true. That's not true? Oh, okay. So that's good then.
Just before I came here this morning, yes, I sent off to the obstetric anesthesia digest a review looking at mefentamine possibly being superior to phenylephrine. And remember that all the papers in the last 10 years, and it's a pity that Warwick Nganki isn't here, because he's the one who started this whole thing of ephedrine not being the drug of choice. And he's right in one respect. It depends on what you're looking for with regards to what is the best agent. Generally speaking, you'd think that a mixed agent is not better than a pure alpha sympathomimetic. But on the other hand, in the past, and we're now talking the era of Gertie Marx and Tom and so on, they had found that ephedrine was the better agent. All that Warwick proved, in fact, is that if you're looking at tissue perfusion in the fetus with that agent, then you're better off using phenylephrine. Remember that mefentamine, which is sold in Australia as Wyamine, and methoraminol, which is aramine, again have the same relationship, that mefentamine has more mixed effects than does have methoraminol. So in fact, what's happening is that Warwick almost proved that methoraminol is the best agent, not phenylephrine, but certainly phenylephrine is better than ephedrine, and so phenylephrine is a drug of choice in the US because those are the drugs available to you. Right. But in South Africa, for example, the drug of choice at this stage is methoraminol, and now there's this one new paper that shows that mefentamine might also be better than phenylephrine, and now we're going back full circle to going back to ephedrine, for example. So effectively, it seems to me that there's not much at all in this whole argument. As long as you give something early, you give it carefully, and you give it slowly initially and then increase as required, I think you're probably better off. And with some of the agents, because they've got so short acting, it might be best to use them by infusion, not only just giving a single bolus.
That's true.
I think that's the message really, rather than the fact is which is the better of the agents.
Yeah, but one thing I think we have to remember that if you give phenylephrine in higher doses, it can decrease cardiac output. There is a studies actually where they have done non-invasive cardiac output measurements with phenylephrine. If the phenylephrine exceeds more than 75 mics per minute, actually it decreases the cardiac output. So excessive phenylephrine is also not good. So it's an evolving, I think subject, and let's see where we'll end up in the next couple of years. Now coming to the next one, this is the patient with acute renal failure and preeclampsia with continued seizures. Can magnesium sulfate still be used, and what are the other alternatives? And so Dr. Sunil Pandey, you want to take this?
Well, here we have a very tricky patient. She has renal failure, acute renal failure, and eclamptic, and whether we can use magnesium sulfate. I would like to define what is the definition of acute renal failure. Is it renal insufficiency, or the patient's creatinine level is raised? If it is raised, or is the creatinine clearance? Either way, once the patient has seizures, magnesium sulfate is a drug of choice. You can give the loading dose quite safely, and subsequently you can continue the infusion at 0.5 gram per hour, monitoring the magnesium level slowly, because that is one of the best anticonvulsant the woman has during pregnancy, especially with NEC, when you have eclampsia. And it's quite a safe drug, provided you monitor the magnesium levels, say every 6th hour or every 12th hour, depending on the creatinine clearance the patient has, which is very important. Generally, when you say creatinine clearance, you have spot creatinine clearance ratio, whereas 24 hours urinary proteins. Both are quite sensitive, whatever you have, but you have to keep this in mind. And not to forget the clinical signs of magnesium sulfate toxicity. You have to correlate your clinical signs of dependent reflexes and respirations and other, when the patient, like routine magnesium protocol should be in place while the patient receives magnesium sulfate in the presence of renal failure. And of course, if the patient has oliguria or anuria and the creatinine is raising, then subsequently you have to rethink whether you want to continue magnesium infusion, wherein you have to give in an alternate agent like benzodiazepine. If the patient is postnatal, if the patient is still antenatal, then you can consider phenytoin loading dose.
Good.
Regarding the second question, preloading in preeclampsia. Again, this patient have intravascular, actually they have a fluid deficit, very high systemic vascular resistance, and similarly very high pulmonary vascular resistance. So definitely administration fluid in this patient you have to be very cautious. Again, I would like to go beyond preloading in preeclampsia, because clinically I would like to know to which subset this patient belongs to. If you read the paper by Mabey et al., he has classified this preeclamptic women into 3 subsets, subset 1, 2 and 3. And subset 3 is the one who has very severely elevated systemic vascular resistance, and they may have decreased LV contractility and decreased cardiac output and cardiac index as well. And any fluid challenge in this subset of patient is quite significant. It causes significant morbidity in terms of pulmonary edema, and you have to be cautious. So how do you know clinically which patient belongs to which subset? Basically, we have done a small observational study. I don't know how far it is because we have not correlated with echo, but we have found out that any patient who has a rapid increase in weight gain, like say the patient has gained about 5 to 7 kilos in less than 3 days or less than a week, then this is a patient with subset 3 wherein they have very severely elevated SVR, and this patient's fluid challenge or fluid preloading is dangerous. As such, in a nutshell, preeclampsia doesn't warrant any, you don't have to do any preloading. Even routine cases, preloading is not necessary before a regional. You can just co-load the patient and you can continue your regional technique.
Now, there is one question down the road which I might finish off here itself. Someone asked, what is the role of Lasix in patients with preeclampsia? In
fact, there is no role of Lasix. You should never give Lasix for treating oliguria. You just have to, if the patient goes to a stage of oliguria or imminent anuria, then it's an indication you have to terminate the pregnancy. And you just have to correlate the maternal parameters, the fetal parameters, and appropriately remove the baby. LASIK is just your physically you see, okay, some urine is coming and you sit on her, but the actual pathophysiology, you're not correcting it. And in fact, it causes further decrease in the intravascular fluid volume and it can jeopardize tissue perfusion.
Was there anything more specific in the question? Like, is it LASIK to treat oliguria, or was it in the context of pulmonary edema?
No, it was actually, no. It is a very non-spec. They said, what is the role of LASIK? And I just want to bring in something. There used to be a concept, of giving albumin or colloid and then give the LASIK in order to actually move the, fluid across into the vascular fluid and then promote diuresis. What do you think of that? That concept. Anyone can answer. If anyone in the audience wants to jump in, feel free.
Bhavani, I think the problem with preeclampsia is that in addition to all the pathophysiology at the level of the placenta, you also have leaky capillaries in the pulmonary vasculature. And the problem is that you can never be confident that the albumin you infuse stays in the vascular system. If it happens to translocate, the problem is it's going to hold water on the other side. And so you have to be really careful. And this is a debate which has been going on for the past 30 years in critical care. And I'm sure these people are more sensitive to the same phenomenon. So you need to be careful. And I don't think there's any evidence to support that therapy.
Having treated severe preeclamptics for many, many years, I can't help feeling that we've got it all wrong. We've got it all wrong, I think, because the problem with preeclampsia is not so much what you do, but when you do it. So it's a matter of timing. And to say that you wouldn't preload a patient, I think, is almost as dangerous as saying, I will preload a patient. You have to keep it in context of what you're actually going to do next. And I think that we have this concept in preeclampsia of pari passu, which means that if you're going to dilate somebody, then you must give them some volume. If you're going to give them some volume, then you must dilate them. It doesn't matter what you use for dilatation, whether you use an epidural, or whether you give them some hydralazine, or whether you put them on a SNP infusion, or TNG, or whatever. But whatever you're doing, you have to also replace the volume at the same time. If you have somebody with a CVP of -12, which is where the severe preeclamptics, and you don't preload them, and then you decide to give them an epidural, then don't be too surprised if the blood pressure falls out altogether. So I think that the main thing is timing. And it's the same with LASIK, I think, with furosemide. I think there is there is never a reason for giving furosemide while the baby is still on board. But in the postpartum period, if you have a patient who's looking like she's becoming oliguric, who is still passing some urine, and who has received 85 mils per hour or more over and above the urine output, and they're still passing some urine, then it is probably quite all right to give a small dose of furosemide. But in this situation, you're saying that the patient is already maximally filled, and then it makes sense, and she's still got working kidneys, and of course, if she's not passing any urine at all, giving her furosemide is probably going to make a difference anyway. But the answer is, I think there is probably one small indication, postpartum for furosemide, and only if you're replacing them at slightly higher volume than they're passing urine.
Yeah, I think I actually agree on that line. That is how my clinical practice has been right for many years, and even at Brigham I occasionally do that. Dr. Subramaniam, yes.
I just want to add one subsect. We get a lot of late referrals to our hospitals, which I'm sure Sunil also faces. We get patients with raised INRs of 2.53 and, with no urine output. Now, I have to give some FFPs to take them to the theater. So I have to make room for that volume. Okay, so that's one indication where, I might have to give some furosemide. And I think, that's one indication where you need to try and create volume. Because I can't dialyze that patient pre-op, and I have to create space unless, short of giving a GA in the recovery room or putting the patient on
ventilation. Can I suggest that you create the volume, though, not by giving them furosemide, but by actually dilating them up a bit better. So either starting a nitroprusside infusion and give it slowly, or by giving them a decent dose of hydralazine, but in either case, create the volume, the space that you need, by actually dilating them up. They've got most of them, and I think that the studies you suggested earlier on, and the ones that Sunil was speaking about, the subsets, these subsets have been around for a long time. Hein Odendahl in South Africa, and more recently Wasserstrom and Cotton have proven that not all preeclamptics are the same type of preeclamptic. Some of them are on the basis of raised systemic vascular resistance, but also some of them are on the basis of very high cardiac outputs. And some of them have those high cardiac outputs before they get pregnant. So really, some of the preeclamptics are actually set up already before they even get pregnant for developing preeclampsia. So in those situations, I think it's probably best. So it's only in the very small subgroup. In the Cotton and Wasserstrom classification, they're what are known as group 5. But for groups 1 and 2, and possibly even 3, which are the vast majority of all preeclamptics, the initial treatment should always be preload and dilate, or dilate and preload. And then in groups 4 and 5, one of them is beta blockers, and if you work in intensive care, you'll know that there are a few patients in pulmonary edema who do benefit from beta blockers because you offload them. And then group 5 is the one where you might actually use furosemide. But so you have to know what patient you're dealing with.
Yeah, I just wanted to spend a little time on this. It's a very important subject which you see in your practice very often. So moving on to the next one, she is a 36-year-old pregnant lady with ICP raised and because of the tumor, and the blood pressure is 220 by 120, admitted to the hospital. What is the management, obstetric and neurosurgical? It's a little bit of a very, vague question with a wide, but I will have Dr. Anjan to, to just highlight few important points rather than the full details. I'm sorry, 36 weeks rather. Right. She's 36 weeks.
We've had, I think, maybe it's one of our residents from our hospital. We've had such a case in the recent past. And what exactly happened was that because first thing is this patient has to be at a place where there is a neurosurgical facility available. And if I remember right, she underwent a cesarean and the removal of the tumor at the same sitting. First the Caesar was done, which was followed by the tumor removal, and she got a GA, and the blood pressure was controlled earlier on. By the while, because the neurosurgical setup is always different, there are a lot of logistical problems involved, but we got her operated, and both the fetus and the mother were fine. So I personally feel that you press a button, call everybody around, the neurosurgeons would want to have a look, and if it is a diagnosed tumor, in India you could come up with this kind of a patient who just, like Subra said, you just called and somebody decides to do a CT and they find something. So if it's a planned patient and he's come like this with the results because she has been referred to a tertiary care center, it is worthwhile to get both the surgeries done at the same time. Get the blood pressure down, meanwhile prepare the neurosurgery theatre, get the Caesar out. And I don't know what happens in every other place. The maternity wards and the systems are very far away from the neurosurgical systems. So that's a bit of a problem. But if you can manage that, that would be the right approach. Getting down the blood pressure with the normal things will not be an issue. You could come down to reasonable levels for a GA, and all the problems of a GA in a full stomach patient with chances of raising up the ICP. If you intubate and the intubation is difficult, this patient could be a Malampatti 4 or something, then it's all a problem. But the plan should be a combined surgery with invasive monitoring.
Here the problem is the patient has raised ICP. Here the tricky thing is, if at all you want to reduce the ICP, certain manuals, whatever medical therapeutics or hyperventilation, what are the modes you choose to reduce the ICP, it is going to jeopardize the fetal circulation. So that is what is the challenge here. So I was...
That is the question.
Yes, because you wanted to reduce ICP. At the same time, the factors which you use that reducing the ICP, either mannitol or furosemide or whatever. If you give a GA, you try to hyperventilate. When you hyperventilate, you will have you try to hyperventilate, you will cause CO2 levels reduces. There shift the ODC left. That again it will cause a ODC shifts in the, baby gets, you will subject to the hypoxia. Okay. So it is like what is good for, you are going to do for the brain. The mother
I don't think it's as difficult as you're making it out to be, in the sense that she's 36 weeks, so she's basically deliverable. There's no doubt about that. Secondly, the management of this patient is not much different to anybody else with raised intracranial pressure. So, for example, a patient would raise intracranial pressure from a bleed. Essentially, the principles are always the same. Sit them up, give them oxygen, hyperventilate them so that their ICP comes down, and then control that blood pressure. What you do next is almost certainly going to be a GA. This is not something that you can do a craniotomy on with an epidural. So you're not going to put an epidural in this patient, and there's no point anyway, it's got raised intracranial pressure. And then I think it becomes a neurosurgical type of anesthetic, right? So probably TCI TIVA with propofol, with a rocuronium infusion, with, if we have a Mallampati 4 airway, perhaps with rescue with Sugammadex. But again, that whole period of intubation needs to be covered so that we don't get any rise in ICP during the intubation. So same situation as usual. Nitroprusside infusion, nitroglycerin infusion, minibolus diazoxide, tribetafan, whatever happens to be the drug of the week in your place. A bit more propofol than usual, those sort of things. Once they're intubated and ventilated and sitting, you know, and the ICP is down, it doesn't really matter which you do first, but it would make more sense, as Professor Tricker said, to actually do the cesarean section first, get the baby out, and then go on to do the craniotomy.
Yeah, I can exactly tell you what happened for this case. It's just a coincidence that you saw it and we have it. It's exactly the same thing. We don't have remifentanil available, though the GA after the baby was delivered was propofol and rocuronium and fentanyl infusion. The surgeons did their job, ventilated her. This patient never had any invasive intracranial pressure monitoring. This ICP raised was a clinical diagnosis, and 36 weeks is I think we are more than happy to live with the patient. It has to be a GA. What thing was talked at that time was, it was just an academic discussion which was just ruled out, and you could ask a postgraduate, could you do an awake craniotomy on her? Well, it's not really on. 36 weeks, I want the baby out first, and then do whatever we want to do. Awake craniotomy was just one of those things which you normally tend to ask somebody whether he's aware of it, it can be done or not, how to do it. But no, it has to be a GA. You have to take care of the blood pressure surges. Well, if I remember right, a nitroglycerin was used in this patient, and then the baby delivered and the neurosurgeon took over.
And once you have an open head,
yes, pressure.
And can I just add, just want to add one point, that the baby is going to come out within 3 minutes of your incision, so it doesn't matter. So
whatever the hyperventilation or what doesn't going to...
Whatever you do, the baby is out.
What about the giving of mannitol for this patient to reduce the ICP? Mannitol? Mannitol?
Did you use
Any role of mannitol in this patient to bring...
We're talking 3 or 4 minutes. Mannitol takes 6 hours to be decent, and even in the acute phase, you won't see much effect. If you have the head open and you see what happens when you give mannitol and look at the brain, it doesn't come down that fast anyway. So, you know, I think get the baby out, control your ICP with different things. Hyperventilation is as good as any, if not the best, right? And the hyperventilation doesn't even have to be done surgically. You can ask the patient to hyperventilate before you start your surgery. But instead of doing her flat, do her a bit head up, right? Make sure she gets plenty of oxygen, and then do your standard anesthetic as per usual. Not for a cesarean section, as standard as per neurosurgical anesthesia. It doesn't matter if the baby has a bit of fentanyl on board, we can always ventilate the baby. It doesn't matter if the baby has alfentanil on board, it doesn't matter if the baby has a bit of remifentanil infusion, so what? You see, it doesn't matter if you're using, I wouldn't use succinylmetonium, for example, in this case. I'd probably use a rock bolus and rock infusion, and if the worst comes to the worst, I'd reverse it with Sugammadex, you know, if that's the case. But remember, with these patients, the whole procedure is going to take 2.5 hours between the Caesar and the craniotomy. I think it's going to take quite a while. So basically putting even a big bolus of rocuronium is not going to even worry me very much, even at the levels of...
No, you don't. Mannitol pre-op was never used. But once the neurosurgeon starts operating, he's so very fond of saying it's bulging, mannitol, it's inherent in them. So that was mannitol after the baby was out. So nobody was not really bothered after the baby was out. Everybody was bothered, but it is, I hope you understand. Mannitol was always after everything. Once the head was open, mannitol was not an issue. Maybe it was used later on when they were closing up the dura and all that stuff. What becomes a bit of a problem here is, if this patient comes to you, like Subra said, just you have been called and suddenly here is the patient with a history or a CT with a space occupying lesion at 36 weeks. I think if you are in the periphery, refer her. Don't get hold of a neurosurgeon to your center and operate upon that patient. No. he would surely, she would surely need some post-op ventilation. The baby may need some, neonatal, a NICU admission. You should have a NICU and a neurosurgical thing on.
So let's move on to just changing the subject. Now, what are the chances of developing unilateral block while performing CSC in the lateral position? Dr. Purva, you want to address this?
I think there are two ways of looking at this question. If the CSC was for labor or if the CSC was for a section. If it is for labor, what we use is the 0.1% bupivacaine with fentanyl mix. And really it doesn't matter. You're not going to get any block from it. It's more of sensory effect we get than a motor block. So it doesn't matter what happens. And I'm presuming the reason for this question is that while the patient is in the lateral position, you're threading in the epidural catheter, and therefore being in that position while the epidural catheter is threading, what happens to the block. So if it is CSC for labor analgesia, then it doesn't matter. If it is for spinal, then again what I would say is it's only a few minutes while you are performing it, so it shouldn't matter that much. And if you're really worried, then if you do it in the right lateral position and then you turn them over and you're going to give them a left lateral tilt, then you actually get a nice good block afterwards.
And I have another comment to make. Please be aware that if you use a bupivacaine, plain bupivacaine and fentanyl combination, it's actually hypobaric, not hyper. So it's actually the non-dependent portion getting comfortable first. So if you encounter that, it's actually counterintuitive. You would think that the portion that's dependent would get comfortable first, but it's actually the other way around with CSCs. So just be aware of that, and all it needs is just readjustment of the patient's position.
So the baricity of the solution which you are injecting as a CSC mix determines which part, whether it's upper or the lower part, that gets analgesia first. So that is one of the points. You may use a hyperbaric. We use isobaric, that becomes hyperbaric at body temperature. So that's the difference. So moving on to the next one.
One more comment.
Yeah, go ahead.
The most important thing which you need to remember, whoever has asked this question, is the fixation time of the bupivacaine on the neural tissue. It's anywhere between 9 minutes to 18 minutes. So I'm sure that once you give spinal, the epidural catheterization generally is over within 3 to 4 minutes. In case if it's a bloody tap, you end up take another 3 to 4 minutes more. But it's never a problem. It should not be a problem of worry.
Yeah, in a practical sense, it is of non-significance actually, unless anyone is thinking contradictory. Now, moving on to the next one.
Can I make a comment?
Yes, please go ahead.
I think most of the people sitting here who use bupivacaine with fentanyl would be mixing it on their own. So the baricity of that solution is, if you think about baricity, what Sunil says is perfectly fine. I think that question was a bit more academic in nature. Most of the hospitals abroad, you would get this from the pharmacy and everything is taken care of. Everybody sitting here in India would make it themselves. We don't have these drugs coming from a hospital pharmacy which are sealed in a couple of packages in that. If you're really working on baricity, you should be very sure. Bupivacaine, you get two kinds in India. A heavy spinal bupivacaine and the one which comes in a vial, which could be hypobaric. But they don't ask it to be used for spinal. The spinal one which you get is hyperbaric. So you should be clear on that. You don't get isobaric bupivacaine in India. It was not marketed. It was marketed way back by the Astra people. Then the Neon people came in, but they have all been withdrawn.
I remember
Go ahead.
I remember that Brett Goodsey used to always say that the only time that you get unilateral blocks with spinals done in the lateral position is when you leave them on the same side and then you go into theatre and put the wedge on the same side again. So basically you've had them for the whole time in lateral position. So basically it should be quite simple. Put your lateral, and I do all my spinals in lateral. Put them your left side down. As soon as you're finished with your CSC, turn them right side down. And when you get to the theatres, put the wedge back on the left side. That way you've done two changes, basically. And somebody said that it takes a while for a block to establish. But in fact, it might take even longer than that. With heavy bupivacaine, it might be as long as 35 minutes before you get the full extent of your block. And even at that point, you're still getting a bit of changeover from side to side with hyperbaric solutions. With isobaric, it's a different story. And remember that isobaric is the most dangerous in the lateral position, even though most people think that it's worst in the sitting up position. Of course, it's very dangerous in sitting position.
Sure. Now, moving on, elective use of LMA in difficult intubation and post-extubation laryngeal edema and stridor in a patient with pregnancy-induced hypertension case management. Who wants to take up? Dr. Gatt, you want to take this case since you did the first paper? No, he was one of the co-authors of the airway paper by Dr. Malampati. Unfortunately, it didn't go after his name, though. He didn't say Malampati and Gatt at all. It just said Malampati only.
In Australia, we call it the Gatt Malampati. No, it's something. I think that the LMA has been truly one of our methods of salvation in the last decade. I'm not saying that you should do LMAs for elective cesarean sections, though I did at the World Congress in Sydney in 1996 have two papers presented, one with 10,000 and one with 7,000 elective cesarean sections done under the LMA. And I had to accept them because when you have those sort of numbers, you really, you deserve to have your paper allowed at the World Congress. But nevertheless, what I'm saying is that in difficult intubations, there probably is not a single difficult airway intubation algorithm currently that does not somewhere in the middle of it include the LMA. And especially now that we have intubating LMAs. So effectively the answer is yes, there is a great place, right, in difficult intubation to use an LMA. The word elective over there worries me a little bit. I'm not quite sure what they mean. But what I'm saying is that start off by doing your cesarean section rapid sequence induction in the usual fashion. But if you get stuck, definitely the LMA can be life-saving in those situations. Do you want me to answer the second question as well?
Yes, please go ahead. So I'll finish off this subject.
The issue of post-laryngeal edema and stridor is something we don't see a lot in Australia. But when I was at Brigham with Bill Kamen, I remember seeing at least 2 patients who had tracheostomies done for PAH.
I want to ask a question. What about in your practice? You see patients with severe preeclampsia often. Do you see patients with stridor? No?
You see them with upper airway edema a lot.
Can I add a comment?
Yeah.
Yeah, we have had 2 patients. I remember one patient had a sudden change of voice and she was a severe preeclamptic and HELP syndrome, partial HELP syndrome. And we got an elective indirect laryngoscopy. The vocal cord opening was just 4 millimeters. And we are planning for elective tracheostomy in case if she becomes a fulminant HELP or she lands up for cesarean section. But fortunately, she was induced and she delivered. We had an ENT surgeon as a standby just in case if we have to put a tracheostomy. But it's quite common.
Okay. Actually,
thanks. What I was going to say is that if it does happen, you treat it in the normal way. I don't know what you have. How do you treat post-extubation stridor and edema in other cases like ENT? What we have in our recovery room is a cylinder of Heliox, right, which makes it probably easier for stridulous patients to breathe. So they get a mask with helium. They then have a crash cardboard close to their bed. And of course, if the stridor becomes so severe that it doesn't resolve on a bolus of steroids and the helium for a short period of time, and if necessary, bronchodilators, because often the stridor is associated also with bronchospasm. If that doesn't settle, then you need to make some important decisions as to whether you're going to need to intubate them. And in difficult situations, as I've said, I've never seen one in Australia, but I've seen 2 in Boston, you do whatever is required to secure the airway. Okay, so it progresses on to the point where you can't see the cords, where the edema is so severe that I guess you have to do a tracheostomy, or at least a tracheotomy.
so moving on, what is the role of methergin in cesarean section? Is it safe if not contraindicated? Whether oxytocin low dose is enough or methergin to be given if not contraindicated? What is selling is combination of both. And Dr. Kamen, you can answer this.
Okay, the role of methergin is, first of all, yes, it's generally safe. It's considered our second-line drug after oxytocin in situations where the oxytocin doesn't seem to be providing adequate uterine tone. Of course, even if the patient doesn't have the usual contraindications that we think about, such as hypertension, Methogen is notorious for causing nausea. So anytime I give Methogen, I always want to add some antiemetics to the patient as well. And even in the absence of something like preeclampsia or baseline hypertension, it could still make the blood pressure go up. So you just need to monitor that carefully. But as I said, it's now considered the second-line drug. It must be given intramuscularly, not intravenously. So we do use it quite frequently. The second question is a little bit more vague. I'm not quite sure what they're asking, but...
is the person who submitted this question here? Okay, no? I don't see. Okay.
Well, I'll try to answer as best I can, though. First of all, the trend recently has been to give less and less oxytocin. There have been several studies done looking at the ED50 and ED95 of oxytocin for cesarean sections, both elective cesarean sections where there's a very low risk of atony, and more emergent cesarean sections where there may be a higher risk of atony. But still, the ED50 for oxytocin seems to be roughly between 1 to 4 units. Now, that's extremely low. That doesn't mean that if you give everybody 4 units, they're going to be fine. Remember, ED50 means that some patients are going to need more. So, certainly be flexible and judicious with this. But the point is, you don't need as much as we have been giving before. And
no, I changed
we'll get to that in the next question in just a minute. So, can we go back to the last question?
Yeah. Let me see if I can go back.
So here's what I think the mistake people make, though, is that in patients with atony, particularly if it's been a very long labor, like an oxytocin induction that's been going on for multiple days, the patient may have a very downregulated uterus and be very unresponsive to oxytocin. And I think the mistake that people make in cesarean sections is just to keep giving more oxytocin and more oxytocin and more oxytocin and more oxytocin, often at the request or the urgency of the obstetrician. The more proper way to deal with this is to use other agents. And almost it doesn't matter what other agents you use, but Methogen seems to be the second-line drug with other drugs we can use as well. But Methogen, I think, should be given quicker rather than later, rather than pushing more oxytocin. And this is related. We can go ahead to the next one because it's related. The obstetricians are not happy with low-dose oxytocin. Some prefer 20 units of oxytocin and 500. Well, the issue there is not how much oxytocin you give. The issue is contraction of the uterus. The studies are quite clear about how much you need. And again, just like previously, I think that the mistake people make is just keep giving more oxytocin rather than switching to other agents earlier. Just as a little bit of perspective, our standard mixture of oxytocin is 30 units in 500 mLs of fluid, but it almost doesn't matter how much you mix it up. What matters is how fast you give it.
Can I just add something to that? Just wanted to say that we had the same problem with our obstetricians and giving 20 units in 500 mils or 40 units in a liter. But now the Royal College guidelines is we give it as an infusion and it's 10 units per hour. So there's no issues about how much you give and things like that. The other issue came up with the Scottish maternal morbidity review, which came with the CMACE last year, which suggested that because of the persistence of the obstetrician in trying all sorts of combination of oxytocin, you're actually prolonging the lack of tone of the uterus and actually predisposing them more for the chances of PPH. And there was a suggestion that you should use ergometrin earlier and rather than persisting with all the different doses of Sint. And of course, our problem was that midwives use a combination of Syntocinon and ergometrin, which is called Syntometrin, which anyway is not available here. But that was the other issue as well. So move to early ergometrin if you think there's a problem.
I just want to add one thing to that, which is that our third-line drug tends to be Hemabate or the 15-methyl carboprost. But after that, something which has become very popular in the United States is misoprostol, also known as Cytotec. So I'm just curious, is that available in India? Yes, available? And yes, okay. So we're using this because it seems to be very effective, and it also seems to be almost free of side effects compared to the other drugs, which have some significant hemodynamics or pulmonary side effects. So misoprostol has become very, very popular, and I think rapidly we'll see this move up in the algorithm to become more of a second-line drug.
Go ahead, please.
Actually, just to make a comment on when to give your oxytocin agent, because the thing is, I think one should remember that the cardiac output to the uterus is about 30%. But when a patient actually becomes hypotensive as a result of blood loss, the cardiac output moves away, or rather it doesn't become 30% anymore. And so when you give your oxytocin, I suppose 30% of whatever you're giving goes to the uterus. If we actually look at the way your juniors actually administer the oxytocin, they don't actually give it when it is time to give it. Half the time when the baby is already delivered, when the blood loss is extensive, then only they remember, yes, it's time to give the oxytocin agent. In fact, one of the critical areas to focus on when you want to control hemorrhage is, please give the oxytocin as soon as the shoulder is presenting, or as soon as the opportunity to give it is present, when there's no way the uterus will contract and the baby cannot come out. That means as soon as the baby is on the way of no return, give the oxytocin agent so that you don't have to suffer the massive hemorrhage, have blood distributed away from the uterus, and your oxytocin doesn't work on your patient.
See, I did my residency in mid-1970s, and that is how actually I was taught at the time. You know, as soon as the head and the anterior shoulder is out, start giving thing. But that has slowly actually fizzled out. So actually, Sunil, I want to ask you one question. What about your obstetricians? Do they say wide open pit after the baby delivery? It's very common to hear, at least in our practice, wide open pit. They just want to see everything going.
Generally, that way we have control over the peripartum period, perioperative period. And what we generally do is just we give 5 to 10 units as soon as the shoulder is out, and that's it. And the second line of drug in our center is carbapenem. And after a single dose, if the patient still, if the uterus is atonic, then we go on to the PPH protocol, where you can give carbapenem every 15 minutes up to maximum dose of 2 milligrams. And after third dose of carbapenem, if the uterus is still atonic, then we go for methergine. And despite that, if the hypotonicity prevails, then the surgeons take a decision to lynch the uterus.
Okay. Now, for how many hours postpartum you continue oxytocin?
Well, this is exactly what I was going to come to. Basically, the situation currently is that ergometrin has turned down to the third line drug, in that Syntocinon is the first agent we give, and there's currently a new drug on the market called carbetocin, which is basically sold as Duratocin. And basically it's the same price and as effective as Syntocinon, which is synthetic oxytocin, but it's actually much longer acting. It's got a 12-hour approximate half-life. The one thing to do, and not forget, is if you are going to monitor your ergometrin, the biggest problem is not so much the nausea and vomiting, is that it causes coronary artery spasm. And coronary artery spasm in the presence of a patient who's bleeding, for example, and who has a low cardiac output because of an atonic uterus, is that it can be quite nasty. So one thing that you must do is to monitor, especially your ST segments, to see that there's no coronary artery spasm happening when you give the stuff. And also remember that boluses are the greatest risk to these patients, both with Syntocinon and with ergometrin. With Syntocinon, it's mostly vasodilatation. With ergometrin, it's mostly hypertension and coronary artery spasm.
But on the other hand, the reason why I brought this wide open pit is, studies have shown that oxytocin produces coronary vasospasm too. So sometimes actually they had some patients where they developed chest pain even after oxytocin. And that's why I was very curious to ask all of you, and that we have to exercise some caution on how we give these drugs. And there is, there's no time actually.
Bhavani, can I just,
go ahead, please.
I'm asking a question because I might be introducing a controversy. Because in my practice, the usual sequence of uterotonic agents would be oxytocin first, then prostaglandin, and finally methergine. Yeah. But I heard Bill say, that he would consider methergine as the second choice. Is there a difference in the recommendation? Because I don't know among the Indian audience what is the choice, your sequence of choice. In my practice, it is usually oxytocin first, followed by prostaglandin, followed by methergine, and for reasons already explained.
Sunil?
Second drug of choice is carboprost.
And what about Dr. Subramaniam in your? Carboprost. Yeah.
I think we use still ergometrin second.
So it's, what should we do, 45 minutes? How long do you want to go?
Ask the audience.
No, let's find out if there are. Bhavan, if I may suggest, let's find out if there are anybody in the audience
So anyone
whose
in the
questions are not
audience who
answered.
has questions? Now, I have one question that came. Let us see, what's this question? In epidural procedure, if accidental dural puncture occurs, pass an epidural catheter and keep it for 24 hours, was taught in this conference. Well, that is what I said in the morning, right? Please explain how it works. And I think I did complete that process during the question hour, saying that it is probably produces some sort of an inflammatory response, and when you take off the catheter, it then it seals off. And I also said that when they combine all the studies, they found it was about 51% versus 66%. If you leave the catheter for 24 hours, it was 51%. If you leave it, it was 66%. But when they used it as individual studies, it was statistically not significant. But however, there was a percentage difference when you add up all the studies. Then the next part is preference of analgesia in GA for lower segment cesarean section before baby delivery. It says before baby delivery. Dr. Arvind Palnaswamy, you want to take this since you're talking too much on the neonatal brain development?
Oh, yeah.
He's getting you the question and the mic.
Well, the question says that what's your preference for analgesia in general during general anesthesia for lower segment cesarean section before baby delivery? So what we typically do is we actually don't administer any opioids until after delivery, because if you think about it, the baby is usually born within a minute or two after induction and intubation once you secure the airway. And typically, at least in our practice, we administer either a hydromorphone or morphine after the baby is out. And just remember that patients still, even the drug which you administered for induction still hasn't redistributed within the first 3 minutes. So we typically reserve analgesics after delivery. And then stick with, it depends on the consultant, and maybe Bill has a different opinion. But this is typically how we practice in our institution.
What is your usual induction delivery time? Induction delivery time, I'm talking. What is your maximum you had? I mean, all these things matter when the induction delivery time go longer. And particularly if you have a patient who has multiple adhesions, there are previous surgeries, myomectomies, and they're doing cesarean section, they'll be there for 1.5 hours to get the baby. I feel very great when we do regionals there, because otherwise, and sometimes I wonder, suppose if you had given GA and left it for 1.5 hours, what would happen? Did anyone had a 1.5 hours GA before the baby came out?
No.
Okay, so, probably that's why we are doing more cases under regional, and probably,
I think this concept of induction delivery time has done more damage to obstetric anesthesia than possibly any other fad I know of. Felicity Reynolds, I think quite rightly, said that probably more babies have died from the tremendous urgency that seems to happen because of the induction delivery time. If you think about it, it comes from a New York study that Gertie Marx had done, which had volunteers from, what's the prison? Syracuse? Is that the prison that they were doing it on? On volunteers who were given general anesthesia for 15 minutes, 30 minutes, 45 minutes, an hour and 15 minutes, and an hour and a half before delivery of the baby. And guess what? The babies, after an hour and a half, were suppressed, not surprisingly. This is where the whole concept of this piece of nonsense comes from. How many esophageal intubations have happened because of this tremendous urgency, to deliver the baby very, very quickly? We have agents like propofol, which are so short-acting, basically, that the induction delivery windows that we used to talk of 30 years ago are nonsense, absolute nonsense. We have, the induction delivery sequence has changed dramatically over the last 20 years. We have never used thiopentone sucks. We've always used ketamine, thiopentone sucks, and now ketamine, ketamine, propofol sucks, and more recently, ketamine, except in the preeclamptics, propofol, and rocuronium, with Sugammadex rescue if necessary. So really, I think that the induction sequences have changed so much that all this nonsense about getting the baby out in 3 or 4 minutes is a piece of nonsense. And likewise with the analgesia. What the neonatologists need to learn is that babies born of GA are always going to be anesthetized.
Of course,
So,
I mean,
regardless of what we do.
No,
which
but
means that they have to hand ventilate the baby, perhaps. But
Yeah,
so
but-
what, you know?
no, but
it doesn't kill them.
No, you may be right in the elective circumstances. Of course, if there is a fetal distress and there is a urgent indication, probably under those circumstances, because the baby delivery becomes a crucial thing. I think let's call it a day now because it's already going beyond our time. Thank you very much, and